Va a empezar el doctor Malcolm Bell discutiendo la estrategia farmacoinvasiva y respondiendo ya de antemano la pregunta que el auditorio le haría al final de cualquier charla, ¿no? Argumentos a favor o en contra de esta estrategia y cuál sería el tratamiento coadyuvante en estos pacientes. Malcolm.
Thank you very much. I've already expressed to you my appreciation for the invitation to be at this meeting yesterday and how much I really enjoy being here with you. And also just to echo the comments that have been made by a number of the international faculty, and I think it was expressed very nicely by Harlan last night, that this is a meeting of the highest academic standard, and I learn a lot from just sitting here listening to the speakers and to the questions and the discussion here in the lobby. So this morning I have been tasked with talking about the farmacoinvasive strategy, the pros, cons, and optimal co-therapy. I have, unfortunately, no financial disclosures to make. But again, just like yesterday, I'd like to frame this by starting with a clinical case. And this is not a made-up case. This is a patient I looked after a couple of years ago. He was a 51-year-old gentleman who was seen in his local emergency department. He had chest pain, which had started 30 minutes previously. And you can see here that he did have a number of risk factors. On exam, he appeared to be uncomfortable. According to the people who saw him in the emergency department, he was hemodynamically stable, although I think it's worth pointing out that his blood pressure is a little bit on the low side. He had no signs of any cardiac failure, and this was his ECG. And I don't think there's anything subtle here. This was clearly what appeared to be a very large anterior MI. Now, the point here, though, is he is at a non-PCI hospital. And the nearest PCI hospital, which happened to be Mayo Clinic, is approximately 160 kilometers away with a total estimated air transport time of 75 minutes. So that's air transport there and back to pick up the patient. And so this is in a rural area that we're basically connected by fairly open highways. So what's best for this patient? And maybe you could just look through these options. I won't ask for a vote. But these are the questions that come up. And it's interesting, when I was first looking at the topic that I was given here, I was thinking about that this is a discussion about farmacoinvasive versus primary PCI, and as I explain why in a moment. But then I realized, no, I'm in Spain. There's also going to be an option of just full-dose fibrinolysis and looking after the patient in the local in the local intensive care. So as you think about this, I'll tell you what they did do. The patient was given aspirin. He was given full-dose TNK and unfractionated heparin. Now remember, this is in the United States. He was given clopidogrel. He was transferred to our hospital. He was admitted to the CCU, and this was late in the evening. He was pain-free, and he'd been treated with unfractionated heparin, a beta blocker, and a statin. On arrival, this was his ECG. So this is, clearly reperfusion based on all the criteria that we have following TNK. So next morning, the patient was sent to the cath lab. You can see here that although there is a critical lesion in his LAD, the vessel is patent, and I can tell you without showing the video here that he had normal flow. And he then had a drug-eluting stent placed. And you can see here that his troponin T peak was just 0.22 nanograms per mil, so a relatively small infarct. And I can tell you that his echocardiogram showed no wall motion abnormality when the patient left the hospital. Now, I don't need to preach to this audience about all of the data we have from the farmacoinvasive approach versus just lysis with routine observation, because you've made a very important contribution with the Gratheo-1 study being one of the first studies to demonstrate the utility of this approach. But here you can see summarized the 5 major trials that have looked at this. And you can see here that in yellow, the patients who had routine early PCI after full-dose fibrinolysis had a better outcome. And you can see here that this is from the meta-analysis, just to summarize this, that there is a clear reduction in reinfarction and recurrent ischemia in these patients, both early and late. And the important finding here, of course, is that there was no excess in bleeding observed. And in fact, this really is the basis for the European guidelines, indicating that in patients who, well, I would interpret this as basically turning up to a hospital that doesn't offer PCI or cannot offer, PCI in a timely fashion, that they should get full dose fibrinolysis and then undergo routine PCI with the expectation that maybe some patients are going to need rescue PCI. So these are the updated ESC guidelines, clearly indicating that a farmacoinvasive strategy is the preferred method of reperfusion in a certain number of patients. Now, in the United States, I think it's fair to say that we've had a love affair with primary PCI, and that many people have thought, well, we just don't give fibrinolysis in the United States anymore, and that's simply not true. However, I think there has been certainly a belief among many people that it is wrong to give fibrinolysis and that we should be offering primary PCI. And so people go to great lengths to transfer patients from non-PCI hospitals to other hospitals who offer PCI. And as Dr. Gersh mentioned yesterday, at Mayo Clinic, if someone turns up to our emergency department, they are going to go to the cath lab for primary PCI. We do not give fibrinolysis at our hospital. We have a 24/7 PCI service, and the patient can be in the cath lab within 30 minutes, and we have excellent door-to-balloon times. There is no doubt, though, that primary PCI is the preferred mode of reperfusion therapy for STEMI, but there are some practical limitations to that. And God forbid, if I were ever to have an acute MI, I would want to have primary PCI, but only if I could do it myself. And these are some colleagues of mine in Hanoi in Vietnam doing expert primary PCI, and this is done all over the world. And so even in a city as crowded and with limited resources as Hanoi, they do an excellent job with a primary PCI. And the few weeks that I've spent there, every day, 4 or 5 STEMIs coming in primary PCI, all transradial, excellent outcomes for their patients. But there are some limitations to primary PCI. It's very resource heavy. There are some logistical issues you've got to consider, and I'm sure you're aware of all of this. Now, getting back to the hospitals that are non-PCI, and certainly we heard yesterday when Laura Maurer was talking about Boston, many hospitals there offer PCI. There's a PCI hospital on this corner of the street and another one over here. But there are parts of the United States that are a long distance from PCI hospitals. And this is the important thing that we want to discuss in the next few minutes. And these are some data which, this comes from the National Registry. You can see here the door-to-balloon times of patients who were transferred to another facility for PCI. And I think this is a little bit of a reality check, because as you look here, less than 10% of patients had a door-to-balloon time of less than 90 minutes, and the median time was 152 minutes. So that means more than half the patients were having door-to-balloon times of up to 3 or more hours after the onset of chest pain. So why is that? Well, the United States is a big country. I can tell you here, you can see Rochester circled. That's where the Mayo Clinic is in the state of Minnesota. And this is the area that we serve, and all the other little hospitals there are non-PCI hospitals who send their patients to Mayo Clinic. They do not have cath labs, let alone PCI. But there are some issues we have to deal with. This is the road right outside Mayo Clinic, and in fact I was going on a trip, sitting in the airport to give a talk on the farmacoinvasive approach, and this picture was right on our local newspaper from that day. And my flight was then canceled. But we have weather conditions to contend with, and it's not all year round. We actually have some nice weather. We have a number of helicopters who will go out and pick up these patients. But for about 50 to 60 days of the year, this helicopter can't fly, even in the summer, because we have thunderstorms. And so again, this is the reality of when you have a network of service, when you're going up to pick up patients in helicopters, let alone on the road. Now, this is an interesting observation. I think this is an important study. I'm not going to go into the Dynami 2 trial, but this, of course, was the trial that told at least the Danes that they should be doing primary PCI on everyone and lytic therapy was not to be given, so they could transfer patients very quickly. Well, in Denmark, it's a very small country, relatively flat. They have BMW-powered ambulances. They can get patients very, very quickly. And at least that's what was demonstrated in the Dynami 2 trial. But these are some interesting observations. In Denmark, after Dynami 2, you can see here that there actually were some long delays in real practice, in real-world practice in Denmark. And the longer the system delays, you can see here, the higher the mortality. This is mortality as the hard endpoint. There are no other variables here. This is just mortality. So I think, again, this is just, we have to be realistic and appreciate the fact that if we delay treatment in our patients, the price we're going to pay is a higher mortality in that group of patients. And as I said, just to emphasize, in a country that has a very well-organized system, there are still delays. Now, in Minnesota, it doesn't snow all year round. There are some nice places to see. This actually is a photograph of Minneapolis. This is the Mississippi River and the skyline of Minneapolis. But in Minneapolis, which is about 140 kilometers north of Mayo Clinic, they have a very good system of STEMI care. So similar to us, they're sending out helicopters picking up patients out in rural sites, particularly to their west and to the north. And they've also provided, I think, some important information here in terms of system delays, particularly with respect to transfer delays. And you can see here that they've looked at whether these delays occurred at the referral hospital or during transport or at the PCI center. And these delays can occur anywhere, but more frequently at the referring hospital. And I hope that you can read this, but at the referral hospital, the most important reasons were just simply awaiting the transport, waiting for the ambulance or the helicopter to arrive. There may be delays in the emergency department in terms of getting the electrocardiogram or to recognize that there's a myocardial infarction and then to make the call to activate the system. You can see that the longest delays were diagnostic dilemmas. And you have to understand that in most of these places, there are not cardiologists taking care of these patients. These may be family physicians or emergency room staff or even residents or fellows who happen to be moonlighting in these facilities. And there are some other issues. We've already addressed the issue of weather. And there are some delays at the PCI center, which we won't discuss this morning. And so, if we then get focused on these hospitals that are transferring these patients, there's a new metric that has really reached our lexicon in terms of STEMI care, and that is the door-in, door-out time, or the so-called DIDO time. And this is the time that is spent at the referring hospital before they're being transported. So the moment they come in to the moment they leave that hospital, and they may not have yet received any reperfusion therapy. And in the past, none of these hospitals were accountable for this, but this is now a CMS metric. You can see here data here, this is published just last year, that only 10% of patients had a transfer time of less than 30 minutes. Sorry, a DIDO time of less than 30 minutes. And in fact, you can see there that the median was almost 70 minutes. And the important thing here is that this was actually an independent risk factor for mortality. So patients who had times less than 30 minutes had a significantly lower mortality than the patients who had a higher DIDO time. So it translates into something that is tangible, and that is death or hopefully improved survival if you can get the patient out of there earlier. And as I said at the beginning, I was faced with this dilemma that, well, in the United States, I'm always comparing the farmacoinvasive approach to primary PCI. And I've already shown you the data for farmacoinvasive approach versus fibrinolysis with just watchful waiting. But here's a summary of the data to support the role of farmacoinvasive approach compared to primary PCI. two randomized clinical trials, the second Grathia trial and the West trial, two registry studies, the French and the Amico study from the United States. Together, these basically have shown that the farmacoinvasive approach compared to primary PCI is at least equivalent. In the Amico study, it suggested it might be superior, but this is not a randomized trial, and I think we have to be careful of that interpretation, and as safe. So we're not losing anything by taking the farmacoinvasive approach. And the patients that we are particularly interested in are the ones who present early. These are the patients who have the most to gain by rapid reperfusion. And again, I think that these are interesting data that come from a combined population from the Horizons and Cadillac trials. And you see, these are patients who underwent primary PCI. Everyone had primary PCI in these trials. But the patients who presented less than 90 minutes after the onset of chest pain, you can see there that if they had a rapid door-to-balloon time, that their survival was much better than the patients who had a delayed reperfusion. On the other hand, on the right-sided panel, you can see the patients who presented later, it didn't really much matter if you're a little slower with your primary PCI. Now, this is not something to be encouraged, but what it does tell us that the people who present early are the ones who have the most to gain with rapid reperfusion. And if you think back to the slide I showed you earlier, that the patient is sitting at a hospital waiting for half an hour or a whole hour for the helicopter to arrive, and then to take them to another hospital, and then to do PCI, you can see here that their outcome is going to be much worse than if they had been transferred, instantaneously, or if you had PCI available, or if you had another strategy, which of course is the farmacoinvasive approach. And I think this is an important curve. This actually was a hypothetical curve that was published many years ago by Bernard Gersh and Jeffrey Anderson, but it's actually really now been incorporated into the guidelines. And what this curve tells us, or shows us, is the mortality reduction and the amount of myocardium at risk. And you can see that within the first 2 to 3 hours, this is where all of the gain is to be made in terms of mortality reduction and salvage of myocardium. And so current guidelines really focus on this and would say for the patient at a non-PCI hospital, so obviously they can't go immediately to the cath lab, that the preferred treatment for these patients who present early should be full-dose fibrinolysis and then transfer the patients. And for everyone else, they should be transferred for PCI. Now, this may or may not be relevant to the second part of this. May or may not be relevant in Spain. It certainly is, though, in the United States, and this is the system that we use at Mayo Clinic. This slide is just going to summarize what I believe are the pros, and this is what I was asked to summarize here. So compared to fibrinolysis alone, the farmacoinvasive approach will decrease reinfarction and ischemia. That's been well documented, and without any excess in bleeding. When we compare it to primary PCI, I hope I've made the point here that this avoids delays in reperfusion, which are really built into the system, particularly when you have long distances or these long delays in transferring patients out of hospitals. And I think this particularly is of benefit to the patients who present early, and to remember that, the golden hour. Let's go back, 20 years or more with the fibrinolytic trials. The biggest difference or the benefit in mortality or survival. I don't think there's ever a benefit in mortality, actually. I think it's better to survive than to die. So I think that's a term that we use very loosely in cardiology. But the patients who have the most to gain in terms of survival are going to be in the first hour. And then the logistics are less demanding. You don't have to rush to get the patient there and have the cath lab team waiting. As I said, this is very resource intensive. The farmacoinvasive approach is a little less resource intensive. The cons may be, again, probably not relevant in Spain, where I think the use of fibrinolysis is quite prevalent, but certainly in the United States, it takes some convincing for people to use fibrinolysis, but I think that's changing a little bit based on my experiences in the last year or so. And of course, there's this risk of bleeding and everyone's fear about intracranial hemorrhage, and I'll come back to that in a moment. Then, of course, as I pointed out, in many of these smaller hospitals, we have non-cardiologists making these decisions and then committing the patient to fibrinolysis and then sending them to us. And every now and again, they may get this wrong. I think it's been well demonstrated these patients do very well in transport. Very rare serious complications, and certainly that's been our experience. But, of course, then the only other danger, and I think this is somewhat theoretical, and it depends how soon you're going to offer PCI. Just waiting for that PCI, will you re-occlude? And again, you're going to a PCI hospital, and you should be expected to deal with that if that occurs, and that patient then would undergo PCI. Intracranial hemorrhage, when this occurs, it's a devastating complication, almost 100% mortality. But in all of the farmacoinvasive trials and registry studies, it's about 0 to 1.1% is about the highest that's been reported. Optimal adjunctive therapy. Well, I think this is absolutely critical to the success of the farmacoinvasive approach. It's going to prevent reocclusion. It's going to improve the outcome of your PCI, and it should minimize the risk of bleeding. And I think just in summary, it's clopidogrel. We have no data, as far as I'm aware, of the use of ticagrelor or prasugrel in patients who've been treated with full-dose fibrinolysis, so we still use clopidogrel. And if you look at all of the studies, they've used either unfractionated heparin or enoxaparin. And the only study that's really compared the two was the Pci extract study. But I think that we have to be careful interpreting that, because that was not really a pharmacoinvasive approach. It clearly showed that enoxaparin was better to unfractionated heparin, but these were patients who were treated for 3 or 4 days before they actually had PCI. And as I recall, it's only about a third of patients actually had PCI. So if we're doing this quickly, I think it's really up to you, whatever you're comfortable with using, unfractionated or enoxaparin. So as I finish here, I just want to briefly show you our experience. So these are for the patients at Mayo Clinic who were transferred to us. This does not include the patients who presented primarily in our emergency department. And you can see here, this is over about a 7-year experience, that we've had about 600 patients transferred for primary PCI, and these are the patients who presented later or who had a contraindication to lytic therapy, and then almost 400 patients who had the pharmacoinvasive approach. And you can see here that this represents, a typical MI population. The important thing here is that STEMI was confirmed in almost all patients who had fibrinolysis, and maybe not unexpectedly, fewer patients who were referred for primary PCI. And that may be just some patient selection where we weren't quite sure what was happening, and so we just then had the patient transferred, and we sorted it out when they arrived. Outcomes here, in-hospital death. Now again, these are not randomized data, so you have to be careful how you interpret this. But you can see here that I don't think we're doing anything wrong. We're taking the pharmacoinvasive approach. We have consistently seen better event rates in this group of patients. Recurrent MI, it's going to occur, but very infrequently. Intracranial hemorrhage, we've had 1 patient in primary PCI and 4 patients in the pharmacoinvasive approach over the last 7 or 8 years. Finally, as we look at the practice patterns in Europe, and particularly when we talk about this in the United States, I think it's important to remember that some reperfusion or one mode of reperfusion is usually going to be better than no reperfusion. And I think it's a concern that in some parts of Europe, particularly in Eastern Europe, that there are still many patients in green here who are not getting any reperfusion therapy based on this survey from Wadimsky. And again, in the areas that are having primarily primary PCI, I do wonder whether there are patients who are actually missing out on reperfusion therapy or having very delayed reperfusion if we're focusing just on primary PCI. And again, I think that I showed a slide earlier from Vietnam, and it's fine for me to come and tell you what we're doing here and in principle what we should be trying to do. But I think, again, it always depends on the local region. And so here's, if I go to Vietnam and talking about reperfusion therapy, we're talking about the pharmacoinvasive approach. I showed you they do primary PCI very well. I don't know if any of you have been to Hanoi, but Hanoi doesn't really have an ambulance service. And even if they did, the streets are absolutely jammed with motorcycles. And no one is going to get out of the way of an ambulance. And so they don't have trained paramedics to bring these patients in. And the hospitals in the rural areas, they're not going to put patients into helicopters or ambulances. This is where fibrinolysis is going to be helpful. And finally, and some of you know I'm originally from Australia. Now this actually is a picture of my brother. And, okay, maybe I'm making this up. But would you believe for a moment that there's a patient in the back of this vehicle who's having a STEMI, and he's in the Australian outback, and if you've ever looked at a map of Australia and realized the scale, no one lives in the outback. And you can go for thousands of miles and there's no one, let alone PCI facilities. And so it would be ridiculous for us to talk about the farmacoinvasive approach or primary PCI in the outback. And here he is looking for a PCI hospital. Thank you very much for your attention.
Malcolm, you mentioned that kind of love affair Americans have with primary PCI, and you also showed that this could be also a fatal attraction on that. But I suspect that the Europeans and the Spanish people have the same kind of love affair. And I think that at least half of our patients are with a timing longer than 2 hours before reperfusion. So at the end, what do you think are the barriers to perform farmacoinvasive treatment in these patients?
So it's a really good question. I think it's just the availability of PCI. In a hospital. So if people are living close to a hospital that has PCI, first of all, you've got to have people who are experienced in performing PCI, but you've got to have a service that's available, 24/7, and should be able to demonstrate that they have very short, door-to-balloon times. But again, it's going to. I suspect there are many places in Spain that are nowhere near a PCI facility, and I haven't really emphasized it, but I think it's important that we don't necessarily have to go out and build cath labs in these places, but I think it's important that you have a network of care and that those hospitals know what to do with these patients, and if they cannot safely and quickly transport patients to a PCI facility, and I would say, so that they can have door-to-balloon times of 90 and at the most 120 minutes for the majority of patients, then they should be getting full-dose fibrinolysis. But yes, there are many cardiologists and non-cardiologists who have been led to believe that primary PCI is the only method of reperfusion. I think it's the best, but only if it can be delivered in a timely fashion. So I think, we had a hard task actually convincing the people in these hospitals to give fibrinolysis. But when you give them the feedback and you show patients like I showed there, it works for the vast majority of patients.
I'd like to know your opinion about the timing of PCI after successful thrombolysis. The case you presented, I think you underwent PCI the next morning. Mm-hmm. Many cases, what we see is the patient arrives very early after successful thrombolysis to the cath lab. So the situation is that you come across a patient that is totally asymptomatic, normal ECT segment, and TIMI3 flow, and a horrible plaque. And in some of these cases, when you implant stent, what was a TIMI3 flow turns into a TIMI2 or TIMI2.5 flow. The consensus has been established that the PCI after successful thrombolysis has to be carried out in the context of farmacoinvasive strategy between 3 and 24 hours. Do you think that 3 hours is okay? Is there a need to rush patients into the cath lab when they are symptomatic, or can we delay a bit?
So it's a good question. So the patient I presented, I think I counted up that it was, 14 hours after he had lytic therapy. And as you know, up until a few years ago, this was considered to be a contraindication. You should not take the patient so quickly. But I think that, the studies that have been done, as I said, the Grathia 1 study really, paved the way for this. It showed that, it is, safe and effective. And in fact, in that earlier slide I showed you, the earliest time was about, 1.5 or 2 hours after lytic therapy. Our practice is 3 to 24 hours. And in fact, we've been trying to move it up because actually we can maybe decrease length of stay for the patient. So I think we have good data to support that you can do this sooner. But it depends on adequate, adjunctive therapy. The important thing is the patient's got to have received clopidogrel. Because we don't really want to use a 2B3 inhibitor, so soon after lytic therapy. And we know if we do PCI, within the first hour or so after lytic therapy, this could be a recipe for disaster. There's a sort of a bad milieu of bad humors in the bloodstream, and you have no reflow, as you mentioned. Most of these patients are going to have a significant lesion as the cause for their MI. Occasionally, though, we'll do an angiogram. They've got TIMI3 flow, and there's really not much of a lesion there. And I don't think that we should be treating those. Some of my colleagues will just go and put a stent there because they think that's going to help seal things, but I think that potentially could complicate things. But I think that's the uncommon scenario. So typically, they come to the cath lab, and we'll do thrombectomy in some of these patients, but most of them will just have PDCA and a stent placed. But it's done in an elective setting.
Thank you. I think that the slide that you presented on the long-term results of the dynamic study associating the delays in the system performance and the long-term mortality brings a lot of concern, because sometimes we see presented the results of PCI programs, and we hear that maybe the performance is not very good. We have some delays, but we don't have to worry very much because 30-day mortality is 3%. And one thing that is difficult, that a patient with a large infarction that is completely reperfused dies in 1 month. And some of these patients go home with a very depressed ejection fraction. So maybe it would be better than look at short-term mortality, looking at other indicators, for example, ejection fraction, to evaluate the performance of these programs.
Yeah, I think that those are good recommendations. I think that again, just to emphasize, I think you have to have a network of care, but you've got to document what your times are. So if you're sending patients to a PCI hospital, I think it's incumbent on you to know what the times are for all the patients. So you should have, on a regular basis, feedback on what the daughter balloon times were, what the outcomes were. We actually haven't been reporting ejection fraction early because it often will change. But I think that too often as interventional cardiologists, we're very comfortable and very proud of ourselves in the cath lab. We've got the artery open, and then everything works out well. But the patient leaves the hospital with an ejection fraction of 30%. Well, they may not die tomorrow or next year, but over time, that patient has a scar. I mean, what's the chance that they could die of sudden cardiac death in the future? So, as a patient, I would want to leave the hospital with preserved ejection fraction. So I think that there are some other metrics that we perhaps should be considering, but I think that those data should remind us all that we better know what the performance is in our own hospital or the hospitals to whom we're referring our patients.